Okay, so this is the third and final video of the shock lectures. So we'll start this video with septic shock. Septic shock, we started talking about this first in microbiology. So it starts with a systemic infection, and this infection can happen in the community. It can be community acquired, it can be nosocomial, so it can be hospital acquired. This is something that we need to make sure that we are protecting our patients from, and we can do that by assessing sites of indwelling catheters, so IVs, arterial lines, make sure we are adequately performing oral care with our ventilated patients. So this is definitely a preventable and treatable, excuse me, illness, so that we can prevent septic shock from occurring. So let's take a trip back to microbiology. I know it's been a while. That was way, way back in first semester. So this is going to help us treat the patient properly. And you also need to understand the difference between types of bacteria for your boards. So let's start with gram positive. Remember, gram positive stain purple, okay? And gram positive bacteria have a cell wall, and it's not very complex, and they release endotoxins when they die, and when those cell walls are broken down and they produce waste. And then we have gram negative. And gram negative have a more thick, complex, well, that's not a very good circle, but let's try that again. So gram negative have a very thick, complex cellular walls. That makes it harder to break down. And they release exotoxins. And it's these endotoxins and these exotoxins that make the body so sick, that lead to sepsis. Okay, so it's the body's response to these toxins that makes sepsis so bad. So we can have cytokine storms, we can have inflammation mediators, and eventually our cells are going to create cellular debris because they're fighting off infection and they're dying. So it's the body's response that's going to make it even worse. So septic shock, we've talked, it's a systemic total body infection that's going to cause organ failure. So organ failure is going to be the key to know once we get to a shock level. We can be septic without going into septic shock, but once we start seeing signs of organ failure, excuse me, that's when we know we're in trouble. So we have massive vasodilation. So that means this is going to be a relative shock problem, relative hypovolemia. So it's a distributive shock. We have impaired distribution of our blood volume, right? We're losing fluid due to this vasodilation. Volume is going to shift, so our blood pressure is going to fluctuate, okay? The biggest populations that are most at risk are grapes and raisins, our old and our young, okay? Grapes and raisins, grapes being young, raisins being old, as well as those who are immunocompromised or are prone to get sick, like our cystic fibrosis patients and COPD patients, okay? So our sepsis criteria. This is what we're going to look at to determine mortality and the stage that which our patients are in. So our SOFA, which is sequential organ failure assessment, we're going to look at a table on the next page, and we're going to look at our lungs, our kidneys, our liver, our blood, and our central nervous system, okay? So we're going to score this, and we'll go over scoring in just a minute. We can also see signs of DIC, which is what you see in the picture here. So that's when there's pressure in the capillary beds, and our capillaries start to rupture our capillary beds. So you can see DIC here. Our lactate is going to be greater than 2. And we're putting this all together. This is not individual. So we score the SOFA. Our lactate is greater than 2. We have hypotension, and that requires a that requires a vasopressor like vasopressin, norepinephrine, to even get a mean arterial pressure of 65 millimeters of mercury or greater. So here's the table that I was talking about, and this is the SOFA table. And this, we are going to look at our lungs. So our P to F ratio, PaO2 divided by FiO2, and then we're going to score them. So we're going to score each organ. We're going to have the parameter, which is, this is what we're looking at, how many points they get. So 1 would be the best score to get. We want them to have lower points. The higher the score, the more points they have, the more severe situation it is, okay? So lung, we're going to look at the kidney, so we're going to look at I's and O's, so urinary output, or creatinine. We're going to look at our liver, we're going to look at bilirubin. We're going to look at blood pressure and catecholamines. Blood, we're going to look at the platelets, so are we clotting? Are we clotting too much? Are we clotting not enough? And then we're going to look at our Glasgow Coma Scale, okay? And that's putting that together with our lactate, and then if vasopressors are required to maintain a MAP, and that's going to tell us our prognosis. It's also going to tell us what catecholamine dose we're going to give. So dopamine and epinephrine or norepinephrine are all pressors. They're going to increase our blood pressure. Because remember, dopamine, epinephrine, and norepinephrine are all natural catecholamines. But our body is not producing enough. We need a little extra help to maintain our blood pressure. Okay, to treat septic shock, we want fluids. We want crystalloid solutions. So we want lactated ringers or albumin. Albumin is going to help pull that blood back from the interstitial space back into the vasculature. Vasopressors, so dopamine or norepinephrine. Antibiotics, so this is going to be, we're going to need to get tests, right? We're going to need tests for culture and sensitivity, so blood tests, testing maybe the wound or the area that is causing the site of infection, okay? Inotropes, remember, inotropes are cardiac drugs that are going to help the heart squeeze. It's going to help take some of the workload off the heart muscle, so that it can squeeze with a little extra help, so we get that stroke volume that we need. Organ support, so that might be, an example would be CRRT, which is continuous renal replacement therapy. So that's kind of a quicker version of dialysis. So if our kidneys are failing, we could have CRRT. Mechanical ventilation, right? But we want to make sure we're using lung protective strategy. So with mechanical ventilation, lung protection is going to be imperative because we're likely to develop ARDS with septic shock due to all the inflammation. Okay, we also want to make sure that with mechanical ventilation that we're not decreasing the cardiac output or decreasing hemodynamic stability. So we need to make sure that we're watching our PIPs as well as our cardiac output. We don't want to decrease the amount of blood returning to the heart, okay? Okay, so you might hear the terms warm sepsis and cold sepsis. So warm sepsis, this is going to be when we're compensating. You can see that the blood pressure is going to be normal, right? That false sense of security. There's going to still be urine in the catheter, Our fevers increased, we're pink and warm. This is when we're going to draw for lab values. We're going to be tachycardic, tachypnic. So it's early septic shock. This is when it's still reversible. We're going to look at white blood cells. We're going to look at differentiated white blood cells to see what kind of confection is going on. So shock fully hasn't set in. We're still in the compensating phase. And then we have cool sepsis. So this is going to be the progressive phase. And if we don't catch it, it's going to become refractory quickly. Many hospitals have sepsis alerts so that we can prevent it from going to the refractory phase. So the cold phase. So now we're decompensating. We have decreased mental status. We have cool, clammy skin. We would still probably have a fever, hypotension, low respiratory drive. So it's going to be shallow and respiratory rate is going to be lower. We no longer are having urine output. So this is when it's going to be cold and progressive to refractory very quickly. Okay. So lab values we're going to see. So you have to know your lab values. So we are going to have neutropenia. So that means low neutrophils. And you're probably thinking, well, if our patient is really sick, why are their neutrophils and their white blood cells going to be, the neutrophils going to be low? That's because once we get to the phase of becoming septic and septic shock, we can no longer keep up producing white blood cells. So we're going to have these increased bands. Remember, those are baby white blood cells, specifically neutrophils, because our body's trying to keep up, but we cannot. So increased bands. We're going to be hypoxemic, and we're going to have a metabolic acidosis, okay? And that's due to cellular death and their toxins. We're going to get blood enzymes. So you're going to see an increase in AST and ALT, which are both for the liver. You're going to see an increase in BUN as well. And that's going to tell us that our liver and our kidneys are now going towards organ failure. So we have organ involvement. So make sure that you know what kind of test results you would see for septic shock. Okay, let's talk about anaphylactic shock due to a severe allergic reaction. So what happens in septic shock is massive vasodilation due to a histamine release. So our body's releasing all these mast cells are degranulating. We're releasing inflammation mediators, which are triggering this massive vasodilation. Okay, so this is going to be a relative hypovolemia. And we are going to have a fluid shift. So fluid is no longer staying in the vasculature. And this is an emergency. So make sure that you understand how serious this really is. And it can become fatal within minutes. So patients are more likely to clot if they experience anaphylaxis. We're going to see arrhythmias because we are no longer oxygenating the heart. And ventricular dysfunction. There's the ventricles are going to have to work harder. And respiratory failure, because we're going to have that massive swelling, and it is going to prevent oxygen from coming into the lungs, and then we cannot adequately transport the oxygen to the tissues. Okay, and this is most common in people with multiple allergies. I like to use this picture as an example. So if you've seen Zombieland Double Tap, you know that this is the character that ate almonds and was having an allergic reaction, an anaphylactic reaction, and they thought that she was becoming a zombie because she turned red and she started swelling up. So I just like to show that part. So these are common causes of anaphylaxis. So nuts, fruit, and shellfish are going to be the most common cause. Food are more likely. Strawberries, bananas, I know, are another one. So make sure that you can list some of these and recognize these. So this is going to be important to ask questions, know what you're looking for. What was the patient doing when they started having the itchy, scratchy throat and started coughing? Were they eating? What were they eating? What kind of food do they serve there? Um, what was in the food? Did you bring the package with you of something new that you ate? So those would all be great questions to ask. Drugs, if somebody's on a new medication. I had a kidney infection a long time ago, and I was living in Colorado Springs, and I went to Memorial Hospital, and they started me on IV Levaquin, which is an antibiotic, and my throat started to itch, and then I started clearing my throat a lot, and I had no history of drug allergies in the past, and I was wrapped up like a mummy in one of those silver space blankets because I was cold from the saline, and I couldn't get out. Luckily, a friend was there with me, and she ran and got the nurse, but I wasn't able to breathe, and I went into anaphylaxis, and just they shot me in the butt with epinephrine, and it worked, but it was very scary. Another couple minutes and I would have died. So it's very serious, and anaphylaxis can happen very quickly. Okay, latex is another big one. Bees and wasps and snakes. Anti-venom. So anti-venom that we give for snakes can cause a reaction as well because it's very similar in structure to the venom. Blood products, so albumin, packed red blood cells, plasma, all of it can cause that. And contrast dyes, so that's important to note. If your patient has a shellfish allergy, contrast dyes are typically, for CTs and MRIs, are typically made from shellfish. So that would be something to note when you are taking a patient to CT. Okay, so symptoms. So first of all, this usually happens on the second exposure. And that's because the first time that your body has it, it realizes it doesn't like it and it starts to build antibodies against it. And those antibodies are attached to the mast cells. So the antigen slips into the receptor on the mast cell and degranulates the mast cell, and then the inflammation mediators are released. So second exposure is more likely. And reactions can continue to get worse and worse with continued exposure. You can also be fine with something to eat, for example, eat strawberries your entire life, and then all of a sudden have this type of reaction to it. Okay, the skin is going to become flushed and warm or almost hot. It's going to turn very red, right? Know your signs and symptoms of inflammation because that's what's going to happen here. Nausea, vomiting, diarrhea is going to be your GI symptoms. Okay. Respiratory, we're going to have severely swollen airway, right? Inflammation, severe swelling. Okay, your tongue is going to swell, and that can obstruct your airway. So this is a respiratory emergency, and we need to make sure we have a patent airway very quickly. Loss of consciousness. Hypotension is going to be a big one, right? Because we're losing that volume. And with respiratory, we'll also have an increased mucus production because the body's saying, there's something in here, I don't like it, so I'm going to secrete everything I can. Something else you might see is drooling as well, okay, because that airway is swollen. So basically what happens with an anaphylactic reaction is everything is overstimulated. We're releasing inflammation mediators. We're going to swell, secretions, producing more saliva. So everything is overstimulated. So treating shock. Having a patent airway is going to be our first priority. We want to make sure that we get an airway patent before we have swelling and it becomes an even more emergent event for intubation. When we intubate, if there is time, the most skilled practitioner should be doing the intubation, because intubation in itself is going to cause more airway trauma. So the anesthesiologist, if we are in the hospital, would be a great one, especially for kids, seeing as their airway is smaller. Knowing where your emergency airway cart is going to be imperative, knowing where that's at. Making sure that we know where the Crike kit is, which would be part of the emergency airway, just in case things go south even worse. Epinephrine. Epinephrine is a potent vasoconstrictor. So when I say epinephrine here, if you have a known allergy, for example, and you have an EpiPen, it's going to be IM, intramuscular. So we want to make sure that we put it in a large muscle. So the thigh, the butt, and this is because those muscles are highly perfused. So it's going to go to systemic circulation quicker. So it's going to act faster. So think of large muscle group. Antihistamines, right? We want to help prevent any more inflammation mediators from continuing swelling. A continuous neb with a bronchodilator may be needed. That's not going to be our first thing we do. Remember, for the airway, we want to make sure it's patent first. Epinephrine in the hospital, we can do IV steroids. So systemic, we want systemic corticosteroids. Fluid therapy is going to help treat hypotension. And if we don't treat this, death will occur. So the airway will swell, and we will see death. So traumatic shock, like we talked with hypovolemic shock, this is just a part of hypovolemic shock. So traumatic shock, remember, is going to be hemorrhage or hypovolemia that has to do with soft tissue damage. With traumatic shock, the initial injury, so the initial phase, is going to stimulate that sympathetic nervous response. So we have the increased heart rate, increased cardiac output, because the body wants to deliver oxygen to that site of injury. So this is going to be the compensation phase. Okay, so this is going to be the initial phase, and then the early response is going to be the compensation phase. You can also have nausea, vomiting, and diarrhea. So what's happening is the tissue is interrupting blood flow, right? We have actual hemorrhaging leaving the vasculature, so this is going to be absolute. And then if we have like a crush injury, we can have hypovolemia because our capillaries and our vessels become more permeable. So we're losing fluid and blood volume that way. The metabolic acidosis is happening because we have an increase in lactic acid. Okay, lactic acid. So it's going to be an even bigger issue. We're going to have more problems if we have involvement of the heart and the lungs. So severity is going to depend on what tissues are involved and how many injuries we have. So lung injuries and shock. Flail chest. Patients can become hypovolemic depending on the pressure of the heart. So you can see in this illustration down here, it has to be 3 or more ribs that are involved, and we have injuries, breaks on both in two or more places. So as we inhale, and excuse me, and the diaphragm drops, that part of the chest is going to come in and press on the lungs. And then you can see it's going to squish the heart on this side. And then when we exhale, that part of the lung is going to come out and it's going to squish the heart on this side. Okay, so if we have a large flail chest, we can have hypovolemia or hemodynamic issues based on the squishing of the heart. So here, if we have our vena cavas being squished, we're not getting that adequate blood flow. And on inspiration, we're going to have issues with our stroke volume because the heart can't get that good squeeze because it's being squished out. And this would also make it a cardiogenic shock because we are not able to adequately squeeze and get the blood flow out. And then cardiogenic causes hypoxia, right? Our heart's no longer getting the oxygen that it needs, and that can lead to arrhythmias. So we could have multiple shocks at the same time. So it's imperative that we treat the underlying issue. We could have an obstructed airway, so a tension pneumothorax. We can have pulmonary contusions. So all of these can cause the shock to progress faster. And that concludes this lecture. So make sure that you are looking at treatments, causes, and then cardinal signs and symptoms that would set each individual shock apart from the others.